Okay, guys, we'll give it like maybe 30 more seconds, just let everybody get in, and then we'll go ahead and kick this off. Okay, let me go ahead and get things started. On behalf of the QC, my name is Mike Rosen, and I'm going to be the general moderator of this session. I want to just take a second and recognize Kayla Parnell, who is our current fellow who put all this together. And in fact, has put the whole year hernia school agenda together and put a lot of work in this. I think, as you can see, we had a huge response to this. So I think there's a lot of interest and a lot of excitement about this. And it's a huge opportunity for residents, fellows, attendings, industry, that we can all really kind of share our knowledge on these different topics that are relative to hernia surgery and abdominal core health. And I just want to thank Matt and Sergio for being willing to present their part of this as well today. So I'm going to let Kayla kind of take it away. She'll go through the basic agenda, what we're going to do, and we'll go ahead and get going. So thank you very much.
Awesome. Thanks, Dr. Rosen. Yeah, like you said, I'm Kayla. I'm the fellow at Cleveland Clinic right now, working with Dr. Rosen. And I'm part of the committee for the ACHQC with residents and fellows who are also interested in abdominal wall. And we felt like there was a need to kind of just go over the basics and kind of design a curriculum for ourselves as we're learning these complex topics. So the group of residents that I'm working with have been awesome, and we've all done a great part in just putting together a curriculum that's going to expand for the next year monthly. And all of us residents and fellows are going to help present some data just some information on core topics, and then the data that supports whatever we're talking about. And so we have a great year in store, and Matt will be our first presenter tonight. He is he'll be presenting different types of mesh, synthetic mesh. I'll let him introduce himself, and then Sergio will be following this up with the data that supports that. So thank you all for coming, and let's get going.
All right, so I'm just going to share my screen here. All right, well, thank you everyone for coming. I'm Matt Madion. I'm a chief resident at the Medical College of Wisconsin. And as Kayla said, I'll be talking about synthetic mesh options in a realm of other mesh options we'll talk about later. So I have no disclosures. Brief outline, we'll touch on why we need mesh for hernia repairs. And then we'll get into some details on the permanent synthetic mesh material types, and then some of the characteristics we can manipulate within those materials to have some different performance capabilities. And then in terms of questions and comments, if there's any clarifications that are required immediately afterwards, welcome to that. But I think we're going to save most of the broad discussion until after Sergio reviews his papers. So why mesh in general? So the short answer is that it reduces recurrence rates compared to a suture repair. And there's a multitude of long-term studies that have shown that. The image on the left of the screen is from a 10-year study that Sergio will review in more detail, but it showed a significant reduction in recurrence rates of ventral hernias with mesh. There's also been some systematic reviews in the meta-analysis, which is the top right of the screen, which has shown a risk reduction in recurrence rates with utilization of mesh. And this was also been replicated, or at least shown in inguinal hernias as well in a Cochrane review, that image in the bottom right of the screen, also a risk reduction. So the take home here is that use mesh when able, it reduces the recurrence rates with hernias. So what can we look at in terms of the design needs when we're thinking about a construct of a mesh? Broadly speaking, and this is not a complete list, but it needs to be able to be incorporated into the tissue. So it needs to be biocompatible, and there can't be any adverse reactions from a tissue standpoint. The construct in its entirety needs to have durability and strength to prevent recurrence, whether that's through just the raw material strength of the mesh itself, or the durability when the mesh is incorporated in the long term with the tissue. When in contact with intestinal contents, it needs to prevent adhesions. We know that adhesions can lead to obstruction or fistulization. And then with small amounts of contamination or inoculation with bacteria, we need to see a resistance to infection. So broadly speaking, what material types would we consider in the whole realm of abdominal wall reconstruction? We have permanent synthetics, absorbable synthetics, biologics, and then composite, which is typically a synthetic base with another material involved. When we look at the more expansive list of things available to us today, we'll be just touching on permanent synthetics and composites. So absorbable synthetics and biologics, that discussion will occur next month. But this is just a list for your quick review as to sort of what's available right now. So when looking at permanent synthetic meshes, the three materials we'll touch on are polypropylene, polyester, and polytetrafluoroethylene. They've been utilized for decades now, and their use in both open and laparoscopic constructs is varied and broadly utilized, and thus it's also been the most widely studied to date. The right of the screen just shows a couple examples of things that are available to us in those three material types, and we'll get into some details about some of those shortly here. So polypropylene, this is the second most common produced plastic in the world. When used with mesh in hernias, it's a hydrophobic knitted polymer of hydrogen and methyl groups. We'll talk about the weight and porosity in terms of the knitting being able to be altered and affect this characteristics following this. And it tends to react with tissue via fibrotic reaction. Secondly, polyester. The ester that's most commonly utilized with mesh repairs is a ethylene terephthalate. That's just the ester group. It's more hydrophilic polymer. Typically it was multi-filament thread. However, there are now monofilament constructs available as well. Tends to be a little bit softer of material, and with the multi-filament constructs in particular, tends to have lower bacterial clearance rates compared to a polypropylene. Polytetrafluoroethylene, so known to many as Gore-Tex. This is another material that's broadly utilized outside of the abdominal wall reconstruction realm. It's a carbon backbone with fluorine atoms packed between. Originally created by heating PTFE and rapidly expanding it into a sheet. This creates a very inert and resistant to adhesion sheet. However, the microporous nature of that sheet prevented any bacterial or cellular clearance. Thus, the concern there being low mesh salvage rates, which we'll touch a little bit more on that as later on as well. But PTFE has now been formed into polymer construction in woven or knitted similar to polypropylene or polyester. The benefit here being the material strength itself is stronger. There's less adhesions compared to those two materials, but with better bacterial clearance compared to its equivalent microporous sheet. So those are the three major base materials that we've looked at and have utilized historically speaking, and those are also incorporated into what it's called a composite mesh. And generally speaking, a composite mesh, when utilized in our senses, is a tissue separating construct. So it's a base polymer with a peritoneal barrier utilized for intraperitoneal settings. The intraperitoneal tissue separating nature of that barrier allows a neoperitoneum to form. So most of the materials utilized do resorb over time, and the required timeline for a mesothelium to form is between 5 and 7 days. So all of those last longer than that timeline. However, PTFE is also utilized. That's a permanent construct. There's regenerative cellulose, a hyaluronic acid, fatty acid, collagen construct, and then polyglycolic acid and trimethyl carbonate is actually a material that's being utilized in the resorbable synthetic constructs as well. So it's actually being used as a base polymer too, which we'll talk about in later lectures. So just looking at some of the composite mesh examples here. So on the right of the screen, you can see some of the timelines that these barriers last. PTFE lasting indefinitely. then the regenerative cellulose lasting just 2 weeks, whereas the polyglycolic acid trimethylcarbonate construct lasting up to 6 months. And then when looking at some of the base polymers here, this is just some examples of how the different materials can be manipulated. So, PTFE, you have both an expanded PTFE base polymer, and then in the case of Synacor, it's a knitted PTFE. Pyritex and Symbotex are both examples of the different multi-filament versus monofilament constructs of polyester, and then you have a variety of polypropylene. So it's also worth noting in the realm of composites, Ultra Pro, which it's not necessarily a barrier mesh, but there are 2 different material constructs within a knitted construct, and it's equal parts polypropylene and then absorbable monofilament, which is the same material that's utilized in monocryl. So half of the material will resorb over time with Ultra Pro, and I'll touch on how that affects some different characteristics, or at least weights of the mesh later on. So just going back again, refreshing on what we've covered so far, we've covered the permanent synthetics and the composites in a relatively broad and quick method. Absorbable synthetics and biologics are something that we will touch on in different utilizations next month. But some of the characteristics do overlap in how these are constructed and knitted. So it's worth noting those beforehand. Once again, too, thinking about what we need from the characteristics of the mesh, we need incorporation, we need durability, we need the prevention of adhesions when able, and then we need resistance to infection. So the characteristics we'll talk about the construct of the material itself, so how we actually create the mesh, and then the material property of the mesh once it's created. We'll then look into porosity and weight. These are probably the 2 most important things to examine and discuss moving forward. And frankly, those affect the contraction of the mesh and the bacterial clearance profiles. But we'll touch on those 2 aspects as well. So how can we create this mesh? Well, historically speaking, some of these materials were woven. The issue with woven mesh is that they come unwound relatively easily. So a majority of them nowadays are knitted or warp knitted. And the benefit of a warp knitting process is that you can still trim the mesh and it doesn't come unwind, or that you don't lose the construct in its entirety. Non-woven or laminar examples would be expanded PTFE. That would be considered a laminar construct. And these can also be knitted in anatomic configurations. So as I'm sure many of us have seen in terms of anatomic inguinal constructs, they can also be knitted in an anisotropic form. So they have different tensile strengths in different directions. There's a decent amount of variability from that construct. But once the mesh is created, what properties does it need to withhold in terms of the physiologic strengths of the abdominal wall? And it's recommended that all of these tolerate a 22 to 32 newtons per centimeter force of tensile strength on the abdominal wall, and slightly less for the groin. And I think pretty much all of the meshes that are available to us have a burst strength of that, at least when they're ex vivo. There is some studies that have shown that, at least with the lighter weight meshes, that there is some decrease in tensile strength over time when implanted in the abdomen, but all of them still withhold the tensile strength required of the abdominal wall. And then elongation or elasticity, once we get into discussing some of the heavier weight meshes, do have a less elongation or elasticity compared to the recommendations, but whether that's a sort of affecting the patients down the road is still be determined. So porosity of the knitted mesh, this is a pretty significant characteristic in the range of the holes in these knitted mesh. The offerings tend to range from less than 0.5 millimeter to up to 4 millimeters. It's been shown that a larger pore size allows more physiologic integration with the tissue, and this creates less of a foreign body reaction within those holes and allows for a conversion to type 1 collagen, promoting a higher tensile strength as the tissue integrates. And with less foreign body reaction comes less contraction which is also another adverse effect that we try to avoid. There also has been some studies that have shown that the shape of the pores may also contribute to the strength. So hexagonal shape was shown to have a higher tensile strength, but it was just a single study itself. The theory, or I guess not even necessarily a theory, the science behind the fact that the larger pore sizes allow more physiologic integration is a concept of bridging fibrosis. So if you have too close of a pore size, as we talked about in terms of that fibrotic reaction with the foreign material, the fibrosis bridges to the next polymer, and it creates basically an encapsulation around the mesh, which doesn't allow a proper tissue integration or cellular integration between the polymers. Counteract that with a larger pore size where you don't have the bridging, and it allows for cells to integrate in between that material. So that's the theory, or not necessarily the theory, that's a study that showed that as to why the larger pore size is more desirable. But with pore size, we also look into mesh weight. And this is something that has multiple classifications that have been defined, but roughly speaking, it's the density of the mesh material. For the concept of our conversations moving forward, we'll consider heavyweight mesh to be greater than 75 grams per meter squared, medium weight being 40 to 60 grams per meter squared, and lightweight being less than 40 grams per meter squared. Intermediate mesh, interestingly enough, I think there's one mesh available that I was able to find that falls within the intermediate category, but suffice to say that there's really nothing available to us within that category currently. So until that becomes available, we'll consider that intermediate mesh. And then just the right of the screen is just sort of an example of the variety of meshes that have been created or available globally. Not all of these are still currently in use. So just looking a little bit more in detail about weight and porosity, weight and porosity, pore size are not inversely correlative or anything like that. And it completely depends on the manufacturer and what they have created and offered. I'd like to point out here that the Ultra Pro mesh, as we talked about earlier, has that absorbable construct to it. So the weight would actually be considered to change over time after that monochrome filament dissolves. And then, oh yeah, the Versatex is the only mesh that I saw that fell into the intermediate weight category. But also with that is the concept that although we've measured and we have defined these weights and pore sizes, this isn't necessarily something that is clearly defined on the label of the mesh. So for example, barred soft mesh, it's a weight of 44 grams per meter squared and a pore size of 2.7 millimeters. But on the packaging that you are able to find, at least when you're looking through meshes or something like that, it just defines itself as a large pore monofilament polypropylene. So it's important to keep in mind here that these are sort of characteristics that we need to know as surgeons, but may not be readily available to us unless we've done our research beforehand. Another example here is Symbotex, it does label itself as a composite mesh, but its weight is 64 and its porosity is 2 by 3 millimeters, but it just considers itself a monofilament polyester. So it doesn't really even comment on the pore size. Some of these can be looked up with a quick Google search and finding a little bit more surgeon-specific literature from the websites, but it's not standardized, I guess is my point. And there has been some discussions of trying to standardize it, but that would take some political will, which I don't think is currently available. So when thinking about mesh weights, the goal here is to balance a concept of integrating the least amount of foreign material possible. And lightweight has been shown to have more physiologic cell turnover compared to heavyweight meshes, and the theoretical benefit being less foreign body response, better tissue mesh interface compliance. But the data on this is mixed, and this is not a comprehensive review of the data. We'll comment a little bit more on some other aspects in one of the papers, but inguinal hernia data there's been open Lichtenstein repairs have been shown to have some support for use of lightweight, equivalent recurrence rates with less feelings of foreign body response or chronic pain in those. But in total extraperitoneal laparoscopic studies, it was shown to have a higher recurrence rate at 5 years compared to a heavyweight mesh. And then in ventral hernia realm, there's been some concern for mesh fracture with lightweight mesh. So the takeaway there is that we're not quite, we don't have quite a perfect sense of exact weight that we need to utilize or strive for. Part of the concept with both weight and porosity is that there's a couple adverse effects here, and one of which is contraction of the mesh, which can decrease the covered surface area over time. So if we're talking about placing an intraperitoneal mesh where we haven't covered or closed our defect, that could contribute to recurrence, as well as the fact that some of the shrinkage is contributive to the foreign body response. And so that could also contribute to pain and discomfort postoperatively. As I mentioned, it's related to the pore size and weight. So larger pore size with that better tissue integration profile tends to have less fibrotic reaction, whereas the higher weight mesh on the better material constructs might have a little bit more structural integrity to prevent that. There's also been some studies that have looked at tacking methods or different tacking types intraperitoneal that may prevent shrinkage down the road. This bottom right of the screen is just an example of one study that looked at the contraction percentages of different meshes. I would say that more than 40% is probably not a tolerable percentage from my perspective. And interestingly enough, that dual mesh was a completely PTFE construct. So when we're talking about that complete encapsulation of a mesh, in that fibrotic reaction could have contributed from that standpoint. So then once again, thinking about we need the resistance to infection, looking at bacterial clearance. So this image was from a 30-day rat study, and it looked at different constructs that were available to us. And it showed that monofilament uncoated mesh had the best ability to clear bacteria. Some composites and laminar mesh were unable to do so. This was 30 days, so some of the composites may have still had their their material coating present. But the take home here is that the monofilament uncoated mesh performed best in terms of clearing bacteria.
Hey, Matt, real quick, before you go off this slide, let me just interrupt you for 1 second. What mesh actually did the best?
The Marlex,
which is heavyweight polypropylene mesh, right?
Yes.
A lot of this stuff has been translated. I'm going to set up Sergio when he talks about some of this, but this has been translated to the profile of the soft mesh, and the ProLite Ultra did well. But interestingly, this animal data, with a huge caveat to that, actually the heavyweight mesh cleared the bacteria the best, which has always been fascinating and kind of understudied. But sorry, go ahead. That's why I think it's such a key thing. We kind of overlook it, but and I don't think we really interpreted this data completely accurately when we did this a long time ago, but it is compelling for an animal study.
And the interesting thing, I think about that is that we're not quite there in terms of the weights. I think it's pretty clear that a monofilament uncoated construct with a relatively large pore size is what's necessary, but the weights may not completely correlate with bacterial clearance. And really, I think thinking about bacterial clearance, that was a rat study. So how can we sort of correlate that with actual utilization? And you can look at that in a variety of ways. Surgical site infections and mesh salvage rates are both things that we can think about moving forward. I think the historic dogma for many people, and particularly with residents, is that biologic mesh is necessary in cases of contamination, and that's not the case. There have been studies supporting synthetic mesh and actually showed less surgical site infections compared to biologic mesh in clean contamination or contaminated open ventral hernias. And then if you do have a scenario of a surgical site infection, can you avoid catastrophic or reoperation or reinterventions with synthetic mesh? And the answer there is also yes. There's significantly high rates of salvage with the synthetic macroporous mesh, and some people reporting up to 100% salvage rates with SSIs. So this was, relatively brief in terms of the coverage of what synthetic mesh has to offer. It's hard to show every single available mesh that's within these constructs, but the permanent synthetic meshes have been the workhorse to date in terms of mesh offerings. Polypropylene, polyester, and PTFE, they can all be broadly manipulated in both their weight and porosity, in their knitting constructs and anatomic constructs. And it's key to keep in mind that the labeling may not be specific on these. So if you haven't seen a mesh before and it's on your shelf, it may not have the information available to you to make a decision on porosity versus weight. And it might be something that would require a little bit more research beforehand. And knowing where your mesh stands compared to other meshes available in terms of weight and porosity, I think is the key characteristic there. Some of the characteristics tend to overlap in their effects, but it hasn't been completely parsed out from that standpoint. There's pretty good evidence supporting use of macroporous monofilament constructs, even in the setting of contamination. But we need a little more nuanced conversation with the mesh weight. And we'll continue with that with Sergio after this. So once again, I thank you all for your time, and I appreciate the opportunity to speak.
Matt, Sergio, before you kick it off, just real quick, I don't want to do too many questions because we're going to do this at the end, but just so we don't kind of miss on this, it might be a good setup for Sergio. So just a couple of comments. So first of all, that was a wonderful review of what has become an increasingly complex topic, which is all of the different products that are available out there. And I mean, at the end of the day, kind of how do we as surgeons make choices that we think are best for our patients to give us the best chance of an outcome. And I think what I would highlight in a lot of what you showed and a lot of the studies that you kind of cited at the bottom, which is what I hope that, meetings like this and the QC can put forward, is the vast majority of the data that we use to help guide us on what mesh we think is best for our patients is actually based on animal studies. And interestingly, most of them are based on kind of more rodent, small animal type studies. And so, the one thing, if you do any kind of laboratory work in the field of hernia surgery or anything with animals, is, just because it works in an animal does not mean that you will get the same response in a hernia type patient. So just as some general examples, when you looked at when we talk about shrinkage of mesh, the vast majority of that is done on kind of small animal or maybe up to small pigs just for cost. And so you're talking about, a mesh this big, trying to determine the difference between 30%, 20%, 10% shrinkage. It's very complex to measure that. And I think we all kind of know, we've used, as a good example, PTFE for years. While there are limitations to that mesh, I think most of us know that the PTFE doesn't shrink 50% in the vast majority of people. So a lot of that stuff is just, that's what we have. And so I think that is the onus of all of us as clinicians to participate in registries and things like this, because we're not going to answer all these questions with randomized trials, but to start to get to the meat of, which of those meshes weights are right for which patient, which porosity is right for which patient, and really get enough patients to kind of answer these questions. And I think that is the biggest message about mesh is we have a lot of unknowns. We have a lot of marketing claims, and it's important for us to have the granular detail of what mesh was used in what patient and what happened. So great talk. I guess I'll turn it back over to Sergio, and then we'll do questions at the end.
All right, let me just share my screen here. All right, great talk, Matt. So now we're gonna just talk about a little bit of 3 papers about synthetic meshes. And I'm Sergio. If anyone doesn't know me, I'm a PGY for a UTMB. So I'm gonna start with these 2 papers. This is a trial that was published in the New England Journal of Medicine in the year 2000 by this group from the Netherlands. And it basically compares suture repair with mesh repair for incisional ventral hernias. And also going to be talking about the long-term follow-up of this trial, which Matt already mentioned a little bit in his presentation. And just to highlight a little bit, this is likely one of the main reasons that we currently use mesh for routinely in hernia repairs nowadays. So it was very interesting to read about these papers. So at that time, 20-something years ago, the authors noted a very high incidence of recurrence for incisional hernia repairs. And most of them were done only repaired primarily. And there was very limited data on mesh repairs for incisional ventral hernias. So the goal of the study was to evaluate the role of mesh for incisional ventral hernia repairs. And there was no previous randomized controlled trial in this topic at that time. So the hypothesis of the authors was that the incisional ventral hernia repair with mesh would result in less recurrence than primary repair. So they enrolled patients between 92 and 98. This was a multi-center randomized trial, and they enrolled patients that underwent elective incisional ventral hernia repair. They only included patients with midline incisional hernias and only primary, what they call primary, which is basically an incisional hernia or a hernia that was a first recurrence. And only small hernias were included, less or equal than 6 centimeters in width or length measured preoperatively. And they excluded patients with more than one hernia, signs of infection, prior mesh repair, or if the patient was planned to undergo another procedure along with the repair. And they look into patient demographics, operative details, complications, and also a little bit about patient-reported outcomes. So they randomized the patients preoperatively into two groups. The first group underwent primary repair with a continuous #1 Prolene suture with 1 centimeter bites, and the other group underwent mesh repair, which was a preperitoneal repair, either with a Marlex or a Prolene mesh, which we just saw in Matt presentation, which are heavyweight meshes. And they use a mesh fixation with #1 Prolene and a mesh overlap between 2 to 4 centimeters. And another technical detail is that the authors did not require fascial closure, and fascial closure was actually only obtained if complete tension-free closure was possible. And as well, if there was any kind of, if they were unable to close the peritoneal underneath the mesh, they will place a vicro mesh to protect the polypropylene mesh from the intra-abdominal viscera. And they follow up these patients basically every 6 months. And if they had any question on the physical exam, they would get an ultrasound to assess for a recurrence. And they also looked into patient-reported outcomes if they asked if the patient had pain or if they were aware of any recurrence. So in total, they enrolled 200 patients. They excluded 19 intraoperatively, and they ended up having 97 patients on the suture repair group and 84 patients in the mesh repair group. And the mean follow-up in those two groups was 26 months. So we can see here the baseline characteristics of both groups, and they are very similar. The mesh repair group is a little bit younger, but that's really not clinically relevant. The BMI is 26, which is pretty hard to get here in the US nowadays. But baseline prostatism was a little bit higher in the suture repair group, and the mesh repair group had a little more of patients that underwent an XLAP for abdominal aortic aneurysm. But again, those numbers are small when considering the whole group population. And I think this is the most important table of this paper is the recurrence rate for both groups. So we can see that the overall recurrence for the suture repair was 46%, and the mesh repair was 23%, and that was statistically significant. And they also divided these patients into primary incisional hernias and a first recurrence. And the primary incisional hernias was pretty much the same findings as the overall studies because they are the majority of the patients. But the subgroup analysis of the first recurrence group, we can see there is an even bigger difference of 58% versus 20% in the mesh group in recurrence rates. But that was not statistically significant. But again, it's likely because of the low number of patients in the subgroup. And the authors also analyzed smaller hernias, less than 10 centimeters square in area, and they saw a statistically significant difference of 44% in the primary repair group and 6% in the mesh repair group. And there was no difference in length of stay or time. And they also performed a multivariate analysis trying to find risk factors related to recurrences. And they found that suture repair, the prior surgery for a AAA developing an infection and baseline prostatism was associated with developing a recurrence. And after adjusting for those risk factors that they found, they still found a 57% reduction in recurrence rates when using mesh. Regarding the patient-reported outcomes, the pain was similar in both groups, but it was interesting to see that all the patients with a self-reported recurrence actually ended up having one. And about 10% of the patients that were not aware of a recurrence actually had one. Now, talking about the long-term results of the same trial, this is the Kaplan-Meier curve that Matt already showed us, but they were able to follow up on 126 patients, which is roughly 63% of the patients that were enrolled in the trial, with a median follow-up of 8 years, which is quite impressive. And they found an overall recurrence rate of 63% on the suture repair group and 32% in the mesh repair group. And they also did the same analysis for the smaller hernias, less than 10 centimeters square area, and they found an even bigger difference. It was 67% in the suture repair group and 17% in the mesh repair group. They also looked into subsequent hernia repairs, and they found the patients that underwent suture repair, 35% of them underwent another hernia repair, while only 12% of the mesh repair group underwent a subsequent hernia regrap in the follow-up of the study. And when they looked into patient-reported outcomes in this long-term follow-up paper, they saw that there was a statistically significant difference in abdominal pain. About 36% of the patients that underwent suture repair had abdominal pain, while only 20% of the patients with mesh had reported abdominal pain. And regarding cosmesis and satisfaction, that was not statistically significant, but all of them benefit the use of mesh as well. And especially satisfaction was directly related to develop a recurrence, so that was also explain why it benefited the mesh repair group. So I think this trial was very interesting to read, and I think it shows that mesh repair results in lower recurrence rates than suture repair for open incisional ventral hernia repairs.
All right, Sergio, hold on for just a second. So great summary of this trial. So I want to kind of point out a couple of things. I have a couple of questions for you.
All right.
So first of all, whenever you get into a field in your life, whatever it is, take a minute and go back and look at kind of the seminal papers of why you got here. Because a lot of times it's kind of like telephone, things are lost in translation about why we're doing what we're doing. So you mentioned at the beginning, but I just want to make it clear to everybody, particularly residents and young folks on this call, is that you use mesh for every single hernia, basically because of this study. And in the world of hernia surgery, there's been 4 hernia-related papers that have made it into the New England Journal of Medicine, and this is one of them. So this is the paper that every single PowerPoint presentation about hernia starts with, and every single thing about mesh starts with. And I think it's such an important trial. But let's talk about some details for just a second. So, Sergio, when you see a patient in Texas who comes in with a 4-centimeter incisional hernia, and you fix it however way you want with synthetic mesh, what do you tell that patient their 5-year chance of recurrence is in your hands with mesh?
I would say about the 10% at 5.
Maybe a lot of people might say 2 or 3%. I bet you most people on this call would probably say 5% or less. But yet, the reason that we're using mesh and the reason that we have all accepted that mesh is worth it is because mesh only gave us a 33% 5-year recurrence rate, which I think none of us think that that's what our data shows. We all think we're better. And most of us think that because, quite frankly, we think we've just gotten better and those guys didn't do the right technique and they didn't have the right overlap and they don't fix hernias the way I fix hernias. But it's funny. This trial has never been repeated with modern techniques to actually see if we're any better. And so I would challenge everybody to kind of take a deep breath and realize that, like I kind of criticized a lot of the data on what mesh we choose based on animal data, it's also important to realize that the results that we think we're getting with mesh is heavily skewed by retrospective data from high volume centers with a bias to show that they're doing perfect hernia surgery. And so even the definition, so let me ask you this, Sergio, how, let's start today. Let's just redo this trial. So how would you define recurrence?
If I feel a bulge on a physical examination, I will consider that a recurrence. But I would probably image most of these patients, to be honest, nowadays.
So we did a CT scan?
Yeah.
So do you know what these guys did?
The physical exam or ultrasound.
It was physical exam followed up by an ultrasound. So I don't live in Texas, but I've been to Texas. How many people in Texas on a physical exam after fixing their hernia do you think you could adequately feel anything?
Very few, sir.
Very, very few, very few. And so, I think this also opens the door to like one of the kind of Pandora's box in hernia surgery that most of us don't really talk about, is that we don't have a standardized definition of recurrence, right? And so we're actually comparing apples to like zebras, because when you look in Europe, they will promote, they have 100% follow-up of their cases, but they're actually using administrative data that I think you even mentioned notoriously underrepresents it, because all they're going to pick up on is people who have reoperations due to having another hernia operation. Versus on the other end of the spectrum, if you just ask people if they have a bulge, it's probably too sensitive, and you're going to pick up some people that might not. And then trying to figure out how you get CT scans and everybody. So I think one of the things we all kind of have to do is wrap our heads around this concept that we're using mesh because we accept a third of the time it fails in the New England Journal of Medicine. We don't know how to actually define recurrence. And any study that's looked at it long-term has seen that the results are not nearly as good as we quote our patients. So Kayla, you have a question. I'll wrap up with this thing is, should this trial have actually been interpreted that hernia disease is a chronic problem like osteoarthritis, that our repairs only last so long and recurrence, in spite of mesh, is inevitable, and mesh actually might just delay recurrence? What do you think, Sergio?
I mean, a lot changed in 20 years since that trial was done. So I think it could be more of chronic disease, especially patients that ended up having multiple recurrences despite of the technique that sometimes they get the repairs. But I think I'm more optimistic a little bit. I think that we would get better results if we do this trial again with more modern techniques. But
well, that is the hope that I believe every young surgeon should have. But it is interesting, if anybody, as you get older like me and you got to go see an orthopedic surgeon for something, you need something replaced, they actually don't think anything different. And I think, I'm not going to steal your thunder, but the next presentation you give, is the mesh any different? Are the outcomes any different? Or is it just the same thing over and over again? Kayla, what do you think?
Well, my comment was, for this being like the landmark paper that made us want to start using mesh for hernias, the way they designed this trial is crazy to me. Like, I think, like, because the way if they were allocated to the mesh arm, it was a pre-peritoneal mesh placement. And they said on page 2 under the methods that their default was to not close the fascia over the mesh unless it was completely tension free. So they don't say how many people they closed the fascia over the mesh, but it sounds like their default was to bridge it. And then the way they looked at recurrences was just by palpation, feeling a fascial defect, and the assessors were not blinded. So like all the people in the mesh group, you would feel the fascial defect that they didn't close. And they mentioned that in their discussion, that that was a limitation of this trial, that, you know, the surgeons knew if they were in the mesh group or not. And so they would take that into account when they're counting recurrences. So like, I don't know how they even came up with the number of recurrences that they came up with, because most of these people in the mesh group were bridged. So, and then if there's a question on exam, then they used ultrasound to look for that fascial defect. So it's just like interesting that this is the landmark study that we are basing, you know, that made us all want to start using mesh, when just the way they defined recurrences was, and their technique was just so different than what we do today. So I thought that was interesting. I think this trial definitely needs to be redone. So let's do it.
I'm getting a lot of texts. We just might, we'll see. If we can get enough small hernias, we'll give it some thought. All right, Sergio, why don't you go ahead? I think you got one more to go.
Yeah. All right, so now I'm going to talk about this paper. It was published in JAMA Surgery last year. It was done by the group from the Cleveland Clinic, and they looked into the effect of mesh weights into postoperative outcomes and patient-related outcomes for open ventral hernia repairs. So as Matt said, weight of the mesh is important, and there has been a lot of discussion lately regarding mesh weights and how can that affect patient outcomes. But there's really a lack of data comparing heavyweight and medium weight meshes, especially for ventral hernias. The heavyweight mesh, a couple of studies have shown less recurrence with using heavyweight polypropylene mesh because of less chance of mesh fracture, but that also has been associated with increasing chronic pain and foreign body sensation, but that was mostly for inguinal hernia studies. And the median weight on the counter side has been shown to have more recurrence a little bit theoretically, and more chance of mesh fracture and decrease of chronic pain and foreign body sensation. But again, there's no previous randomized controlled trial that compare both. And that was one of the main goals of the authors, was to compare those two and see how that affect the outcomes. And the hypothesis was that median weight mesh would improve postoperative pain and quality of life score if it's no difference in outcomes or recurrence rates. So they enrolled patients between 2017 and 2019. This was a multi-center randomized trial in the United States. And they enrolled patients with undergoing open retromuscular ventral hernia repair. They only included elective and clean cases with mesh plan, and they exclude patients with less than 18 years old, non-midline hernias with more than 20 centimeters, and that they were unable to obtain fascial closure. And the primary outcome of the study was pain at 1 year using the PROMIS score. They also looked into 30-day morbidity, a 1-year Hercules score, and also 1-year recurrence rates. So just so everyone is on the same page, the PROMIS score we can see on the table on the bottom is basically 3 questions about the patient's pain. And depending on how the patient scores it, he's going to get a score between 30.7 to 71.8. And the take-home message is the less you score, it means the less pain you have, so the better. And the Hercules score is a little bit different. It's a questionnaire with 12 questions, and depending on how the patient answers it, it's going to be scored from 0 to 100. And the more you score, the better quality of life the patient has. So the more, the better. So just keep that in mind for when we're looking at the results. So these patients were randomized intraoperatively after the posterior rectus sheath was closed, and in either undergoing having a medium weight mesh, which was 40 to 60 grams per meter square, like Matt already mentioned, or a heavyweight polypropylene mesh with more than 75 grams per meter square density. And the follow-up of patients was either in clinic or virtually at 1 month and 12 months. And recurrence was assessed with a physical exam, the hernia recurrence inventory, and or a CT scan. So they enroll a total of 350 patients, 173 in the heavyweight mesh group and 177 in the medium weight mesh group. And we can see that those groups are very, very similar. There is basically no difference between the groups. And just to have an idea of what we're dealing with here, we're dealing with larger hernias in the study that we mentioned previously. So a width of 14 and 15 in both groups. And all of the patients underwent myofascial release. And again, no difference between the groups. And then this table, I think it's very important. It shows the primary outcome of the study, which is the PROMIS score. And we can see that there's no difference between the heavyweight mesh group and the medium weight mesh group in baseline, 30 days, and 1 year PROMIS score. But we can see that the PROMIS scoring decreased from 46 to 30.7 in actually both groups. The results were actually the same in the both groups, but there was a 33% decrease, which means that patients were having less pain at 1 year follow-up. And the Hercules score, again, no difference between the groups, but in baseline, 30 days and 1 year follow-up, but there was an increase in the Hercules score from 35 and 36 to 90 and 86, which means that the patients had significant improvement in their quality of life at 1 year follow-up. But again, no difference between heavyweight and medium weight mesh. And here's the table, we can see the recurrence rates a bit in both groups, and there was no difference in recurrence regardless of the method used to assess recurrence. And that really goes into the discussion that we were having about the other page, exactly what is recurrence. And we can see here that physical examination, hernia recurrence inventory, and CT scan, there were no difference between both groups, but we can see that there were a lot more recurrences reported with the hernia recurrence inventory. But we have to just keep in mind that that's kind of the goal of the hernia recurrence inventory, is to be very sensitive and to capture as much recurrence as it can. So it is kind of an expected result. And in order to kind of define recurrence, the authors had a consensus analysis, and they came up with a 8.1% recurrence in the heavyweight mesh group and a 7.3% recurrence in the medium weight mesh group. And again, there was not difference. And even in a max sensitivity and max specificity analysis, which is kind of best case and worst case scenario when assessing for recurrence, and again, there was no difference. So in conclusion, the paper showed that there was no patient perceived or clinical benefit in using medium weight mesh when compared to heavyweight mesh in open retromuscular ventral hernia repairs. So looking forward to see what you guys think.
All right. So first of all, great job. Those are two great summaries of what I think are, 2 or 3 really important articles in surgery. And so I'm going to start with Sergio and Matt. So listen, guys, we have a lot of folks. One of the beauties of the collaborative is that we get all the stakeholders at the table and kind of, we talk to each other and we have conversations about kind of where this field should go. And so I always look at these as huge opportunities to kind of further the discussion. And I think one of the things that the QC does is we try and further that discussion with data. It's not always the best data. It's not always going to be right, but it's an attempt at striving for the truth. So kind of in all the effort that you guys have put forth to kind of compile all this data, look at the best available data, I want each of you guys to say, if you could ask industry on the call right now, and let's just keep this to synthetic masks, because I think there's roles for absorbable synthetic, there's roles for biologic. For this conversation, we're going to talk about the world of synthetic mesh. What would you think is the ideal construct for a mesh? If you could have it made today, what would you say the general weights would be? And what would you say the porosity and kind of the base material? So let's start with Matt. Matt, kind of compile everything you looked at and what Sergio just showed.
I think based on what we've looked at so far and the information we have available to us, I think in the context of how we define medium weight, heavyweight, and lightweight mesh and the porosity, I would choose a pore size that would be, first off, I would choose polypropylene monofilament knitted mesh in a pore size that's roughly around between 2 and 3 millimeters, and then a medium weight would be sort of where I would fall currently right now.
Okay, let me just clarify. And why do you say medium weight?
Well, because I think when we get into the realm of lightweight, if we're talking about there is some concerns in particular studies that lightweight has some adverse material effects compared to medium or heavyweight. So that's
I agree with the lightweight, but get me away from, why not heavyweight or perhaps even intermediate weight?
So I would say heavyweight hasn't proven itself yet against medium weight, I guess is my point. So I wouldn't necessarily add more foreign material that may not be necessary so far.
Okay. Sergio, you just reviewed that paper. What do you think the difference? I think everybody would agree a lightweight mesh, that was probably too far to the spectrum. So what do you think about the ideal mesh that you'd want?
Yeah, I kind of agree with Matt with the material, the polypropylene monofilament, and the macroporous meshes between 2 to 3 millimeters. But I think that I think the trend is going to be more towards heavier weight meshes, as this trial showed that there's basically no impact on patients on how they feel the repair. And there's really no downside, basically, of using a heavier weight mesh with a possible upsize of less recurrence and less mesh fractures in the long term that we are not aware yet. So I would be leaning more towards a heavier weight mesh, like not crazy heavyweight, around like 80 or 90 grams per meter squared or something like that. But I think that's kind of where the direction is going nowadays.
Yeah, so listen, I think this is really important because I think, again, I like to kind of give a little bit of a historic perspective. Everybody is like, you always have to ask yourself, Matt, like, so why do I think that medium weight mesh is good, right? Because there's not like a tremendous amount of clinical data that did it, but it was kind of, I think at a time when we were all experimenting with mesh, and we felt like, wow, this makes sense. It's really lightweight. We had some early success clinically with clearing contamination, but there's a downside to the reducing the weight, or how that relates to the porosity and whatnot, in that there's the next wave of things that we're seeing is mesh fracture. And these are real consequences, not rare things. Particularly, I think one of the things that might happen is as the mesh gets bigger, it's just more material, bigger hernias. And so that might lead to fractures, more strain on different aspects of the mesh. So I'll answer my question. What I think all this data shows is that there is a category of material that we have forgotten about. And it's probably the best of both worlds. And Sergio, go back a couple slides to where you show, go back one more, I think. Yeah, that one, go forward. Yeah, forward. Yeah, so the bottom of this, I just would kind of stress, when we ask the patients if they feel their mesh at 1 year, it was exactly the same. The medium weight and the heavyweight. It wasn't like people felt a difference in compliance. People felt their foreign body mesh. It's basically a placebo effect, right? Like 20% of people, no matter what you do, will feel some type of response to it.
Okay.
So,
Hey, I can't take it anymore. I can't
ahead.
take it anymore. Seriously,
Let's
I can't.
go, man.
Here we go. You brought
Let's go.
all these impressionable residents and fellows, and you're dealing them the same. So it's funny. After this trial, Mike, it's that awesome trial. You guys killed it. This is great. I drew the exact opposite conclusion than you did. My conclusion was that, okay, these are equivalent meshes. There he goes. There he goes. You can't give me 5 minutes. You had an hour. Give me 5 minutes here. And so, so here's the thing, though. Okay, so wouldn't you say that you would have to err on the side of safety here? Let's just say it that, right? And the midweight product probably has more resistance to infection. I mean, none of us bat an eye to now place midweight macroporous polypropylene, preperitoneal, retromuscular combination there. But if you did that with heavyweight, you're like, it's maybe a little too much for a clean contaminated or contaminated scenario. So if the outcomes are equivalent, why would you not err on the safer side of midweight polypropylene?
Okay, just out of curiosity, what is the data that Prolene mesh is not okay in clean contaminated surgery?
Yeah, no one's looked up the head-to-head difference in weights in polypropylene. So none of us has that information. I mean, Alfie's produced some, a reasonable amount of information with midweight polypropylene. I don't think he's looked at heavyweight.
Well,
So-
I think the best available data is animal studies. And I mean, that's limited, but as I point out to Matt, the thing that cleared the bacteria the best was Marlex mesh.
Right. No, I get that. I get that. But at the same time, though, what you can't ignore is there's a lot of experience with heavyweight Marlex. And we've all even seen, granulation tissue through Marlex and then lifts off the Marlex. But I think we've also seen granulation occur through barred soft, and it just kind of sits on top of that. So again,
Hold on.
I'm not sure it's clear cut. I'm not sure if it's clear cut as saying that heavyweight is preferred based on this information. This just shows they're equivalent in terms of quality of life and recurrence.
Well, actually, Ben, that's not exactly what this trial shows, in fairness, because this trial was set up to show that medium weight mesh had some advantage over heavyweight mesh. This doesn't conclude anything about equivalency, and you would need way more patients to conclude equivalency. I think what it shows is that we didn't find an advantage of medium weight mesh in the way that we studied medium weight mesh.
No, that's fair.
We set out to show that medium weight mesh was better, whether it was safer, less foreign body response, you got less infections, you didn't need to take out the mesh. Ultimately we looked at pain. And I do think this study, by the way, shows that the pain at 1 year was basically, people don't have a lot of pain after ventral hernia repair at 1 year. But Kayla, just since Ben pointed that out, and we use a lot of heavyweight mesh, and we certainly have mesh infections at our place. Kayla, have you seen heavyweight mesh granulate?
Yes, I have.
I mean, Ben, I'm just telling you that you've been told that medium weight mesh does all these things. And I agree with you that it does, but you've never been shown that heavyweight mesh doesn't do it. And I would just caution that mesh fractures are real. We see them and they're devastating. And so to use your safety argument against you, I actually agree with you. Safety is a concern, but I personally think that the medium weight meshes, particularly for bigger hernias, like these 15-centimeter hernias, they fracture a certain rate. I don't know what that rate is, but because of that safety concern, I think if things look close enough to the same, then I think we fall on heavyweight mesh. And I mean, my partners, you guys can kind of chime in as well too. But I think most of us, certainly for open cases, unless we need a bigger piece of mesh than the heavyweight mesh, we use heavyweight mesh.
No, I would agree that if you think during a repair, there's a higher chance of, especially a bridge configuration or the fascial closure is going to fall apart. Heavyweight mesh is probably preferred. But I think for this, the smaller hernias, less than 15 centimeters, 10 centimeter range, where you can get a reasonable fascial approximation without tension, I'm not sure there's data to tell us one or the other that one's better than the other.
Well, let me go to the chat box here and let me quote this guy, Benjamin Paulus, I think. I think that you said that if we look at the data with robust follow-up, it's actually going to be a lot worse than we think. And there's going to be 20% 1-year recurrence rates. And these things fail. I mean, I don't know, maybe this wasn't you who was typing all this, but I think you pointed out that our results are terrible. And perhaps you need to think about kind of getting back on to using a heavyweight material. Again, I don't know the answer to that, but I would just tell you, I was all in on medium weight mesh. And I think all these meshes fracture. Alfie's group has shown medium weight mesh fractures, it's hard for us to show in the QC because it's hard to define. But I think that, I think this is a slow process, but it's not as easy as you think. Wait, there's a question here I'm trying to read. Okay, so Bruce Friedman had some comments about, for more active patients, and are really moving around, they're not thrilled. So again, I think this trial, you got to be careful interpreting it for people who are MMA fighters and all those type of things. Like certainly the people who participate in this trial, like we don't typically see MMA people with a hernia defect of 15 centimeters. And that's certainly not the type of patients that we see. So I don't know if you can kind of extrapolate this to those people. What I would say is, this is 170 people. There wasn't even a trend to a difference in anything as far as feeling your mesh. So I would argue back, again, this is hypothetical arguments. I'm not saying that's wrong, but I would say that in an MMA really active patient, that's the person who I think also is prone to potentially breaking the material. So those type of people, I would weigh more heavily on heavyweight mesh than not. But again, that's a bit of a stretch. So there's a question here about higher BMI patients. No, I mean, we're looking at this. It's not just higher BMI. It's not just bridge patients. It's a complex process why these things fracture. But let me ask Ben and anybody else. Has anybody ever seen a heavyweight polypropylene mesh fracture? I've never seen that in my life. I've certainly seen complications from it, but fracture doesn't exist.
No, I would agree. Mike, the only other thing to keep in mind, because you especially in the clinic have done probably the best job more than anyone in the world in terms of the randomized controlled trial data going into this disease process. The only issue with that approach, though, is when you do trials, you tend to boil things down to one or the other in kind of a reductionist way, right?
Yep.
Whereas, I mean, you guys all know this. I mean, the complexities what we deal with patients is much more than boiling it down to one factor. So that's the important thing, that I just didn't want everyone to assume that, especially with the discussion Mike and I were having, that it has to be heavyweight or midweight. I mean, you ultimately got to individualize these things based on your experience, based on, what you think your technique is. The data is important. We need it. But you can't think about this in terms of black and white. I mean, there are times you would use heavyweight, times it's okay to use either.
It's funny to me, the resistance that we get with heavyweight mesh, and yet the willingness to accept that medium weight polypropylene in a contaminated case is perfectly acceptable, despite poorly matched, retrospective, highly selected data. I don't know. I have a much harder time with the synthetics in contaminated cases universally. Then I just look back and I think we kind of got away from a heavier product for marketing reasons that, I mean, honestly, like made sense, but it hasn't really ever come to fruition. And I'll give you like what I think is a very fair critique of this study, though, that I think maybe is why we're like arguing the same thing, is that the category of heavyweight is a very broad category. And the reality is, and I think this is one of the fair critiques, and be careful how you interpret this data, is that we use Proline mesh, which is about 75 or some places it's listed as 80 grams per meter squared. It's on the low end of the heavier weight meshes, and that there are heavier weight meshes that are much heavier than that. And I think maybe that was, Bruce's point too, is I wouldn't necessarily be putting 140, 150 grams per meter squared meshes. We didn't really study that. Those meshes aren't really available to us. So I think that, it might just be that the difference between, say, 45 and 75, you don't pick up a difference, but perhaps between 45 and 120 or 130, I don't know the answer to that. So I think you have to kind of weigh the spectrum of heavyweight mesh, which our trial is not designed to do that. But I think that to me is the biggest kind of limitation of just lumping everything into, guys, just slap heavyweight mesh and everybody. I think about the mesh that you're choosing. Yeah. Don Seltzer sticking up for me. Thank you, Don. I appreciate it. It's tough to work with Ben every day.
You paid him. There's an Indiana Cleveland connection or something. So
it's Don just speaks the truth. So a bunch of people asked for questions about what predicts mesh fractures and everything, and I we're working on this at the QC. It's just, as kind of Ben reiterated, it's really hard to divide. It's hard to, first of all, measure recurrence, and then it's really hard to figure out the mechanism of recurrence when it's already hard to measure it, and determining whether a mesh just pulled away due to technique or the mesh broke in the middle. I mean, that's not an easy thing to do, but I do think that we all should think about that. Maybe some of the young folks on the call could really kind of work through some of that, because I think that this problem is real. And we don't know. We've looked at this to the best of our ability, but I would just also stress, I do want to agree with Ben on one thing. My concern on mesh fractures is not based on this randomized trial. A randomized trial won't pick up rare catastrophic events. It's just based on my clinical experience of seeing it and just kind of it coming on my radar. But this trial, there wasn't a difference at 1 year of mesh fractures. So I think just consider my concern of mesh fracture to be more of a hypothetical concern than something that is like, hard proven. But to Ben's point, when we interpret data, we have to decide what side of the safety aisle we're going to wind up on, what matters most. And I have very little concern of infection anymore, but I have a much greater concern for fracture. I think everybody's a little different. So, okay, so I'll make some final comments, and then Kayla, you can kind of wrap it up. I think, first of all, thank you to Kayla, Sergio, and Matt. There was a lot of work to put this together. You guys had the highest number of attendees ever at any of our QI or QC core insight. So congratulations. I think that this year on the QC core insights, we're going to try and focus on the entire spectrum of hernias. So we're looking to bring in, at all of your own respective places, please invite residents, fellows, or any other surgeons. You do not need to be a member of the QC to take part in this. We welcome everybody to kind of hear and participate in the conversations. And again, I think the agenda is phenomenal. So thank you very much for putting together. And Kayla, go ahead and wrap it up for us.
Yeah, thank you everybody for joining. But yeah, this is kind of just going to be how the format will go for the rest of the year. Is 2 residents or fellows are going to do presentations, just present the educational bit, and then the second part will be talking about some key papers. We can't obviously talk about all the papers, so I have a selected readings that have to do with each topic if you're interested. But on every invitation, there'll be like 2 key articles that we're going to talk about. So just look for that. And next month will be Dr. Paulos moderating a biologic and absorbable synthetic mesh discussion, and Megan, who is a chief at University of Toronto, and Ben Miller, who is a fellow here at Cleveland Clinic, will be presenting the education piece and the data. So looking forward to seeing everybody next month. Thank you all.
Go Bulldogs. Let's go, Georgia. Beat Alabama. Come on now. All right, guys, get back to the game. Thanks, everybody.
Thanks.